So I'm going to speak about the role of glaucoma progression detection and treatment modification. So those are my financial disclosures, none relevant to this. Keep in mind that POG is defined as a chronic progressive potentially blinding disease. So progressive is part of the definition of glaucoma, and therefore whenever we look at glaucoma, you have to look for progression when you are making treatment decisions. And keep in mind also that the aim of treatment is to preserve the patient's well-being and quality of life. So why do we modify treatment in glaucoma? Of course, we modify it because target IOP is not reached. We modify it because of side effects of medication. We modify it because of quality of life issues, and we modify it because of glaucoma progression. And glaucoma progression and quality of life issues are very closely linked. So if you look at the ocular hypertension treatment study, what you find over here is you found that some patients progressed, and the ones who progressed in the ocular hypertension treatment study were more likely to progress on optic disc findings alone, because that was very early in disease and more disc changes occurred at that time. In the EMGT study, which looked at people with established glaucoma, you find that most of the progression actually happened with visual fields, because once you have damage, functional tests are better at picking up than structural tests. So progression can impact both your structural and your functional measures, and both should be looked at. And when you use a very sensitive field test like the EMGT test, you will find progression fast. And this is only to tell you that it's impossible to assess progression without looking at software. You need to have good software on your machines to look for progression, and you need to use it even if you have it. What about quality of life? So when you look at quality of life, the burden of treatment itself can make you miserable. But that's sort of, once you start treatment, that component does not change very much over time. So once you start treatment, anybody who's on treatment is a little bit more miserable than somebody who's not, but it doesn't get worse over time. Your confidence in the healthcare profession actually gets better over time. The most advanced they have, the more faith they have on us. Anxiety levels are high initially, and they get better because patients know that living with disease is a little better. Daily life becomes much, much more difficult as you get more severe in disease. The confidence in the healthcare, I told you, gets better. Your psychological well-being comes down. And when you look at vision research quality of life, and this is on the x-axis, you have the mean deviation. And you can see that people who are reasonably good fields had fairly reasonable health quality of life. But once you come down here, you can see that it deteriorates dramatically. So the aim of our treatment is to basically try and keep patients from getting worse than -10, -12, because you do get issues at that time. So if you see progression on the visual field or something else, what else do you want to know? Because you're going to take a look, you're going to make a decision of what is the diagnosis, how long is it since treatment was started, how much functional damage is there, what's life expectancy, how many glaucoma medications is the patient on, and what are the factors, are there cataract and other precipitating factors, and based on that you will decide whether to escalate treatment, whether you're going to go the medical route, whether you're going to go the surgical route. And I'm just going to share a few examples with you, and we'll take it from there. So I'm basically going to put down the factors that we looked at: progression, field damage, life expectancy, glaucoma drugs, and whether this is late in treatment or early in treatment, whether it's mild, moderate or severe, whether life expectancy is short or long, and the number of drugs that the patient is on. And on this side, we'll go for medication, and the other side, we'll go for surgery. So this is somebody who's a young glaucoma suspect with a family history of POAG. This is what his intraocular pressures have been like over time. You can see that he was fairly normal in the beginning, then he spiked to 22, 23 in between, and at that point, we made decisions on treatment. This is his disc photos, which how they look like in the beginning, and how they look like now. You can see definite nerve fiber defects in both the eyes. This is what his visual field looks like. This is visual field of over almost 8 years or so, and this is what his OCT looks like. And you can see that the OCT is starting to show some changes in the inferior quadrant. The GCC is also beginning to show you some changes in the inferior quadrant. This is the disc photos in the other eye, and here you can see he had field defects to start with, which are getting a little worse. His OCT parameters are showing very, very marginal changes, nothing much. So he is early in disease. They're seeing only structural changes on the GCC. We're not really sure what the significance is because we're not seeing anything on the visual fields, but he has moderate disease and functional change on that. So the thing to remember here is this is also progression. He has a family history, he has documented progression. This is also something that you need to, and we escalated treatment for him. This is a 38-year-old man who was on treatment with us, and between the ages of 35 and 38, you can see that he's progressing fairly dramatically. Intraocular pressure was on target on 2 drugs. So what do you do now? So this is somebody who's progressing. We actually elected to do surgery, and post-surgery, he has stabilized. So early in disease, you have to look for glaucoma progression more carefully, because you want to pick up somebody who's like this, a rapid progressor, and before he loses significant vision, you need to get him under control. So your threshold for surgery in somebody like this is low. The third is somebody with POEG. Now this person also on a beta blocker and brimonidine, you have reached target intraocular pressure. So if you look at only the IOP, you're happy because in your mind this is okay. But once you look at the visual field, he's getting worse. So now the options available to you are medication and SLT. So he is late in treatment. He has mild to moderate disease. He's on 1 to 2 medications. And his life expectancy is long. So basically, because most of the factors favor escalating medical therapy, you can consider escalating medical therapy in this situation. So this is another 58-year-old, similar situation on 2 drugs, target IOP reached. Medications, I would consider very short trial only here, because the defects are close to fixation. So here, because the field damage is moderate to severe, you might just try escalating 1 medication, see whether you can get something done, otherwise just go in for a surgical intervention on him. This somebody, young man, 38 years old, on treatment for 22 years, on bimetoprost and timolol, target IOP is reached, but he is definitely showing progression. You can see from 99 to 2000 to 2021, there is a change. So the options are medication or SLT. In this case, SLT we are not doing, because SLT does not work that well in a juvenile open angle glaucoma spectrum. And again, long life expectancy is something that we're worried about, but because most of the other factors favor him, we'll just go with escalating medical therapy. The 85-year-old man, PACG, pseudophakic, IOP is borderline on prostaglandin and brimonidine, showing significant change between 2012 and 2020, over 8 years. So once you re-look at the baseline, you find that this change has actually been consistent with time. It's about 3% and 3.2%. So it's not that he's been progressing at this rate from a long time. Whatever we have done hasn't really altered that very much. But his life expectancy is short. So there's no need to be very aggressive here. We can continue escalate medical therapy, and he's not likely to develop anything very severe going forward. Because he's at low risk of visual impairment, you can consider an SLT, because that's a good option here, because to keep his medication burden low. So this is somebody, it's an ocular hypertensive. We have 18 years of follow-up on him, and these are what his intraocular pressures have been like. So he goes up to 24, 26. That's more or less the highest we have seen. And we have one low pressure. I don't know why, but otherwise he's been fairly okay. And this is his combined progression report for both the visual field and the OCT. It looks a little busy. I don't want you to get very confused with it, but you can see on the lower pictures that the OCT is showing some change, especially on the GCC. This is in the other eye. So now the question becomes, you are seeing this progression on an OCT. He's getting worse. And the question is this progression age-related or disease-related? Keep in mind that the OCT has no progression for a group of stable glaucoma patients. It also doesn't know, we also don't know what is the normal age-related loss on the OCT. So in this patient who's an ocular hypertensive, who's fairly controlled, I would not change treatment based only on this, because I'm not really sure of the technology which is giving me information on progression. If I was seeing this on a field, I would definitely have escalated treatment. So when you make a decision in progressing glaucoma, you have to keep all these factors in mind. You have to look for progression. You have to look at your target intraocular pressure. You have to look at age, life expectancy, and threat to vision before you make a decision. But very, very important, I'm glad you put this topic in this presentation, because target IOP is not the only thing to look at. You have to look for glaucoma progression. Thank you.